So welcome back, everyone. I'm just going to give people a couple of minutes to just start filtering through and make sure that everything's working okay. So this next session is all on, there's a lot of diversity actually, physiology, dietetics, paramedics. So we're going to try and get through as much as we can in this session, okay? Please do log in to use a chat box and use the chat box for any questions, and of course continue to use social media. So Rasheda, over to you, please, if you'd like to introduce yourself and your presentation.
Thanks, Rachel. Hi, everyone. My name's Rasheda, and I'm the lead respiratory physiologist, currently managing the Children's Respiratory and Sleep Service. So I am just going to share quickly what we as physiologists do. So just give you a bit of an idea. So we play part in a diagnostic pathway, and so for me, the way I see it is we're part of a puzzle, and we kind of help to put the puzzle together. So just letting you know, so respiratory and sleep science, that's what we classified under, and we come under physiologist and healthcare science. So as I mentioned, we play part of a puzzle. So when we have a patient, we look at the demographics, see, the age, the ethnicity, and then we look at the presenting symptoms. So what have they come in with in terms of breathlessness, wheeze, continuous cough. And then again, we look at the medical history. So, smoking history, if they're adults. For kids, sometimes we look at genetic conditions that may play a part in some of the lung conditions, lung diseases. And then we go on to the respiratory test. So as you can see, it's all part of a puzzle. We cannot just do or diagnose a respiratory condition just based on a test that we do as physiologists. It's all part of a bigger plan. So just to kind of, just as a physiologist, I just wanted to kind of highlight what we look at, which we look at the anatomy and physiology of the lung. As you can see, this is a very simple diagram of the two lungs that we all have. And then what we mainly look at is how open the airways are. And that's what our diagnostic tests usually tell us, is how open or how narrow our airways are. And based on that, we're able to diagnose whether they've got some kind of obstructive lung disease. And also looking at the lung volumes. So some of our tests actually highlight that. We do multiple, many different types of tests, just to give you an idea. So this is what a normal lung function test equipment looks like. This actually performs spirometry, lung volumes, and gas transfer. So our spirometry is just literally showing us how open our airways are. A lung volume test is telling us how big or how much space our lungs, how much air our lungs can hold, so total lung capacity. And a gas transfer test is telling us how effectively the gas from our lungs diffuse into our bloodstream, and if there's any scarring on the lung tissue. Again, this is another test that we do, which is lung clearance index. And what we measure with here is we breathe in 100% oxygen, which then washes out the nitrogen within our airways, and again gives us an idea of how much air we can take into our lungs, or how much the total lung capacity of our lungs is based on this test. It's all pretty much breathing tests, but we have different ranges and different parameters that we look at for different. Again, me here doing a hypoxic challenge test. So again, we do tests like fitness to fly to see if we were to go onto a plane, would our saturation within the plane drop based on our obstructive airway disease or condition that we may have. Other tests that we do are allergy skin prick testing, which gives us an idea of if there's any aerosol. A lot of the respiratory and sleep services look at aerosol allergens, so such as house dust mites, cat fur, dog fur, grass trees, if they cause any allergic reactions on our airways. And then we were able to diagnose that, you've got sensitivity to this allergen. Some services also perform exercise tolerance testing. So this is a CPET test, which is a cardiopulmonary exercise test, looking at how your cardiac output is affected by your fatigue as well as your lung volumes and your lung testing, lung exercise testing. We also perform sleep studies. This is one of our very advanced complex sleep study tests that we do, which is the polysomnography testing, which again measures your EEGs within your brain, so your neuroactivity as well as your respiratory output. In the children's department, this is very rarely used because, as you can see, it looks quite very heavy on the chart to be able to actually sleep with all these wires and signals being measured. So a lot of the services that, a lot of children's services, this is what we do. This is my son, actually, that I created a poster on to help children understand how, what they would be expected to do when they come in for a sleep study. Again, what happens during sleep is your airways close up, and that can actually reduce the oxygen that you get in through from your to your lungs, and then effectively your activity, neuroactivity that can be affected, and the quality of sleep. Just wanted to show you a video. So just going into what we used to do. So this is all what we used to do before COVID hit us. So this is an example of how we do a lung function test. So it would just be sitting here with a patient and asking them to do some breathing testing. Sorry, it's quite a short video, but I'll show that again. So normally we'd sit with them, go through some breathing tests, and explain what they'd be expected to do, and hope for the best, really. But what's happened now since COVID, things have slightly changed. So I'll go through what we started doing during COVID, but here was just a slide to explain. So when we were redeployed, we were volunteering to help in clinical engineering team, because we've got some clinical and technical skills that actually helped in terms of ventilation and CPAP. So we were helping with the clinical engineering team, setting up devices, equipment, ventilation machines, all sorts of machines that were coming in. At that time, it wasn't based on specific equipment. It was any equipment that was available to the NHS Trust that were brought in, and we'd be there to install, deliver to the patients, and troubleshoot. We also supported the ICU ward in terms of, again, setting up patients on CPAPs and ventilation, and also troubleshooting once patients are on ventilation to see, is it too high pressure, is it too lower pressure, any kinks in the equipment. We were there to support the nursing staff in ICU. We've also, again, quite in the second wave, have been helping out with in vaccination clubs. So we're able to, so we go through a training of how to administer vaccinations, and then we're able to assist in administering vaccines. We've had other clinical roles, administrative, as well as just supporting ward staff in COVID and non-COVID wards. And so I think that's a key thing for us as healthcare scientists, is we are able to do ward-based roles as well as technical roles which fall out of our remit. So I think we're quite kind of multi-tasked and multi-talented in that sense, like other professionals are. So, right, so in terms of our respiratory and sleep service, COVID has brought a bit of a change in that we have to now wear full PPE whilst doing our testing. So here's one of my colleagues, Hina Mir, who's in full PPE, and she was ready to start testing a patient. So that's the biggest change that we've had within our role since COVID, is we are now having to wear a full PPE before for our patients testing. Not always nice, mainly because our testing does expect a lot of explanation in terms of how to perform the test, how to get the technique right, because it's all based on patient effort. It's all patient effort dependent. So it kind of, we're having to explain, and if they don't get it right, we're having to explain again, and trying to explain something through a very kind of rigid mask like that. It's very difficult. We've been able to usually, without full PPE, is do demonstrations, but unfortunately we can't do demonstrations now because our tests whilst spirometry test is classified as an AGP, which is an aerosol generating procedure, and hence it creates an aerosol in the air, which then can potentially be a risk to patients in terms in this COVID time. So so during COVID, we didn't actually completely stop our service and shut down the service. We continued, but with a reduced service, and we were wearing full PPE during each of our tests just to keep ourselves and our patients safe. We've also had to look at our ventilation within our rooms of performing when performing tests. So in each of our rooms, we've had to ensure that there was adequate ventilation once a patient was doing a test, a breathing test. If they coughed or breathed out quite forcefully, which one of our tests does involve, we would then have to ensure that once the patient left the room, and we were also outside of the room was left for a fallow time of, say, half an hour to an hour for it to vent out and take any aerosol that could be potentially risk of COVID out of the room system, the air ventilation system, and then we'd be able to see the next patient. So that's affected our service and our pathway quite a lot, in terms of now we're having to wait after each patient before we can get another patient into the same room to do any testing. So it's just a quick overview of what we as physiologists and healthcare scientists do. Again, happy to answer any questions on our roles and how it's changed our services. But yeah, that was a quick whistle stop on what as physiologists we do.
Thank you so much. That was so comprehensive. I literally don't know how you've just managed to squeeze it in to just over 10 minutes.
Oh, wow.
Lots of nice comments. So there's one come through on Twitter. So why is it I mean, this sounds like a really basic question, but it's really important. Why is it important that we take some of the measurements that you talked about? So in terms of respiratory health. So I think what I would quite like as well is to think about the early diagnostic work that you do that maybe people don't know about.
So again, there's a big push, especially now because of COVID, because COVID is it affects the respiratory system. So there's a big push in early diagnosis in terms of a COPD. I'm not sure if anyone, COPD was chronic obstructive pulmonary disease. You've got your asthmas out there. We need to try and get them in as soon as possible if there's any symptoms, so we can treat them early. Because once they're if you let it progress, so asthma is a remodeling disease. So if you let it progress and you see that people are getting asthma attacks, it remodels the airways to a narrow form of what the airways are normally are. So if we're able to pick them up earlier, we're able to treat them earlier, and that's the biggest thing. So there's a lot of work going into respiratory at the moment in terms of creating diagnostic hubs across London and the nation, in terms of trying to find those people with COPD, with asthma, and try and treat them earlier. And
I have to say, being a respiratory physio, there is a difference. And I was that kid that went to the GP, no offense to GPs here, and had like exercise-induced asthma. That probably wasn't exercise-induced asthma. That was probably like more to do with me airway. He pulled out his drone, he got the little peak flow meter out, and he said, blow in that. And I thought, how many lips? Now I look back, I think, how many people have blew into that? Anyway, so then I had to run around the GP surgery 10 times as fast as I could, and then blow it again. And that's how you used to get diagnosed with asthma. I mean, I'm talking 30 years ago, mind, maybe a bit more. But how times have moved on, and it's that precise, and it's about technique, isn't it, with what you guys do as well? It's about not just telling people to blow into a tube or in a box. It's the whole approach you take with patients. I think that's what people don't understand, and especially people who never go to a physiology lab. So this is another thing for all you students out there. I'm looking at the YouTube now to say, go to the lab, say, can I go and spend some time with healthcare scientists, with physiologists, and look what they do. So what would you say about that?
Absolutely, you know, most labs are happy to show people around. It may be a bit difficult because of COVID times now, because I know some hospitals don't allow visitors in, but absolutely go into a lab, see what they do. You only saw some pictures of some of the testing equipment we have at my hospital at the moment, but there's so many different types of tests that you can do, and they're all non-invasive, which is so cool because we're able to kind of get an idea of what the lungs and what the airways are doing without actually going in and actually, you know, doing an invasive procedure. So for me, that's the most interesting thing is, wow, I'm able to actually see what's going on with the airways just by doing a simple breathing test. And like you mentioned with GPs, they used to get a peak flow, but now a lot of the GPs have had spirometry training. So they actually use spirometry now, which obviously is a better test than peak flow. So yeah, it's developing, and there's lots of things going on with respiratory at the moment, as you know, and there will be a lot more with post-COVID.
So one of the things that you guys do is around sleep, isn't it? So there's a really good question about, could persistent coughing and mucus and things at night be something that then you could do diagnostics to pick something up? So there's the diagnostics you can do, and also the sleep diagnostics, isn't there? So do you want to explain a little bit about that?
So again, all based on symptoms. If you're saying you've got these daytime symptoms of productive cough or phlegm, then that would be treated in terms of the daytime lung function testing, looking at medication that can help relieve those the productive cough. But the sleep side of it is what we normally look at is apnea. So any kind of closure of the airways, so complete closure of the airways, which then. So what we're looking, so when we do a sleep study test, that you're on video, you can hear what's going on with the patient. They've got all these signals on. They've got an airflow meter, so which actually checks if they stop breathing at night. And that's what, when we look at if they stop breathing at night, that's when, right, okay, they've got some kind of obstructive apnea. And then based on that, most sleep apnea treatments are CPAP, which is just positive air pushed through your airways via mask, which keep your airways open. So there's a difference. So when you're looking at productive cough and there's things in your airways, then that's something that needs to be treated separately to obstructive apnea, which is sleep studies, is when there's nothing going on, but your airways collapse in the middle of the night. How do we keep your airways open? And that's why putting positive pressure through your ears, through your airway, and keeping your airways open. So again, it's all part of a puzzle. We need to take full history of what's going on, and be able to kind of give or refer you to the correct pathway and see. But it's all very interesting, and you know, we're always up for doing different types of tests.
So another one from social media, I heard that you can also work with athletes. Is that that's getting into more the sexy stuff, isn't it? So what's that all about, Rasheda?
Absolutely. So some of our respiratory labs actually have athletes coming in doing lung function testing, and it's shocking the difference you see with a normal person to an athletic person, and the difference in their airway caliber. So, you know, I normally get about 92% of my FEV1, which is just telling me how open my airways are. If I'm able to get above 90% of the air out in that 1 second, they're pretty open. But some, obviously your COPD and your asthmatics, they tend to it takes longer to get the airways out of the airways. Your athletics are usually 120, 130% FEV1. So that's a big difference too. And that just shows, you know, they're doing something with their exercise, which is open, keeping the airways nice and, you know, dilated. What we do recommend is those with narrowed airways. We do always recommend singing and swimming. They're really good for your airways, so airways and your lungs. So, you know, if you've got any issues with breathing, try and sing or try and do some swimming. Hopefully, that'll keep your airways, your lungs nice and open.
Excellent ping for the talk later on. So on that note, thank you so much for being literally bang on time. Your presentation was amazing, loads of lovely comments. Thank you so much. And you can be contacted on social media as well. I will, once everything's downloaded and the live stream stopped, we'll put all the Twitter handles on, so please do reach out. Thank you so much, Rasheda.
Thanks, Rachel. Thank you. Bye.
Thank you. So our next speaker, slight disclosure here, I have to say. I am very fortunate to work with Raz in the hospital at the Royal Brompton. And I'm delighted today because she's going to talk to us about all things dietetic. And I do just want to give out, all the AHPs have been so phenomenal during COVID-19, but I think the nutritional complications and implications of COVID, we massively underestimated. So Raz, over to you.
Oh, I'm just going to try and share my screen.
Something's happening, that's a good sign. Perfect.
Can you see that okay? And can you hear me okay?
It looks amazing, yes.
Cool, perfect. Okay, then I'll just get started. Thank you so much, Rachel, for having me today. I feel really fortunate to be here, and thank you so much for everyone who's giving up their Saturday to listen to me and everyone else. I'm really grateful for that as well. My name's Raz, and like Rachel said, I'm one of the cardiorespiratory dietitians at the Royal Brompton in London. And today I'm just going to give you a bit of a flavour about my own personal views of how COVID has changed my own practice. So I'm aware that there might not just be student dietitians in this session today. One of the big parts of dietetics is the ability to kind of assess and treat effectively malnutrition. Typically, when I tell people I'm a dietitian, people often come up to me and like, oh, can you help me to lose weight? But this is a question just for you guys, and you can put it in the chat box or you can just think about it yourself. Which of these patients do you think is malnourished? I'll give you a couple of seconds, but I'm also tight for time, so I'm going to move on pretty quickly. So I'm hoping that you've correctly identified both of them. And that's because Bapen's definition of malnutrition is a state of nutrition where there's a deficiency or excess in energy, protein, or other nutrients which cause adverse effects on body form and function. And this is super important, especially in COVID. Generally, malnutrition can be put into two groups, undernutrition and overnutrition, and today I'll mainly be talking about undernutrition and probably be calling it malnutrition. But often when we think about overnutrition, we don't think that those patients can be undernourished. So in this patient group in particular with COVID, a lot of patients are coming in and all their past medical history is obesity. And that doesn't mean that they can't be undernourished. That doesn't mean that their state of nutrition isn't in a deficiency of energy and protein. And it's our job to really help and make sure their nutritional status is as well as possible, to get them as best, like the best care, and to get them as well as possible. Some people are still a little bit hesitant about what I say. Again, a question to you guys. What do you think costs more every year to the economy? Do you think undernutrition costs more? Or do you think overnutrition costs more? And what do you guys think the numbers are? So usually when I talk about this, a lot of people are quite shocked to realise that undernutrition actually costs the government more than overnutrition. One is spoken more about in the media and one isn't. And these are a little bit of old figures, but I'm pretty certain that it's still the case to this day. And it's just really important to keep that in mind, because that's why it is just so important that we get their nutrition correct. You might be thinking, okay, but why is it so expensive? So we know, for example, in some studies that 10% weight loss is associated with a twofold increased risk of length of stay in hospital and a sevenfold increased risk of death. But it's more complex than that. We know that malnourished patients are more likely to pick up infections, things like hospital-acquired pneumonias, also pneumonias in the community, and they might not be able to fight that off, especially if they've got respiratory failure, if they don't have enough muscles around their lungs, like the intercostal muscles, that can also worsen their respiratory failure. We know there's a bidirectional link between depression and nutrition. So if you're depressed, you might have a poor appetite, but also if you're undernourished, you might then feel depressed. And also things like pressure sores. If you don't have enough nutrition in you, then you won't be able to heal well. And this is exactly why it's more expensive, because these patients often come back into hospital and it costs us a lot. Now, I know with the COVID pandemic, one of the most overwhelming things for all of us is where to find information. Dietitians are typically very evidence-based, and we like our research and we like looking into evidence. And actually with a pandemic and a new virus, we don't really have that information as much anymore. A lot of the information I will be discussing is from SBEN guidelines, but of course you can use things like Bapen and BDA to get some good resources as well. The other really good resource is just your colleagues. Just definitely feel free to ask them. With that in mind, I'm just going to make a quick disclaimer that generally kind of the recommendations for this COVID group is higher energy and higher protein. Obviously, if there is a renal impairment, it's just important that you get support for that. So okay, we've like understood a little bit now that there's like undernutrition in these patients could get undernourished, they might not meet their nutritional requirements. But why is this? What is COVID doing? So the first really important thing to mention is anorexia and weight loss. So a lot of these patients are coming in and they have like lost like 30–40% of their body weight. And the other thing I do quickly just want to mention here is cachexia. So cachexia is slightly different to malnutrition. So cachexia is characterized by ongoing loss of skeletal muscle mass, which can't be fully reversed by nutritional support. And that means that these patients are going to lose their muscle, and it's going to really impact their quality of life. In terms of when we were talking before about kind of the weight bias, when these patients tend to lose their muscle, that term is called sarcopenia obesity. So that means they have lost their muscles, but they still might be obese. And that is incredibly worrying for their quality of life. The other thing to mention is poor appetite. You know, when you get a cold, when you get a cough or something like that, your appetite tends to go. It's no different in COVID, and this is a pathophysiological process going on, which is cytokine mediated. And it's really important to explain that to patients because often they feel quite bad that they don't have an appetite, and actually there's a reason for that. And patients can get quite down about that. The other thing to mention is when they do get a poor appetite, obviously we know it's really important to optimize their nutrition. And that's where our amazing catering staff comes up. So working with the chefs and working to try and fortify their food and getting them what they want. And there are times where I've literally gone down to the kitchen and begged the chef, like, please, can you put 6 ice creams in a milkshake? And they look at me like I'm insane. Or I'm trying to get some extra glucose powder into some orange juice because that's all they want. And these small things can really help. And I'm just so grateful that we have such a good team. The other thing to mention is that the people who are giving out food, they are often a really good source of eyes and ears. So definitely make friends with those people because they can typically tell who's eating and who's not, other than the nursing staff. Psychological state, again, the bidirectional link. But the other thing to mention is that when these patients have lost like 30–40% of their body weight, they often lose their identity as well. Imagine losing a third of yourself, literally a third of you. And sometimes people don't know who they are anymore. And that's really huge and impacts their appetite. Although this isn't the same, but we know in, for example, qualitative papers for lung cancer, that often these patients just want their weight loss to be acknowledged, and you don't have to be a dietitian or a student dietitian to do that. Anyone can acknowledge that, and it often means a lot to them. It's also about working with the medical team and the mental health team, because there are times where appetite is so poor due to their psychological state that you will work with them and you will consider appetite-inducing antidepressants, things like mirtazapine, to help with their appetite, and that will help with their nutrition as well. Diabetes, we often know that these patients coming in are diabetic. We know that hyperglycemia, so high blood sugars, are really quite detrimental for anyone who's acutely unwell. It's linked with poorer outcomes. Again, it's just really important just to be mindful of that, working with your diabetic nurse, but also thinking if you're giving them oral nutritional supplements or something sweet, which they absolutely probably need, is there any small tips you can give them? So for example, having it with their meal time so they have their mixed meals so the blood sugars don't spike up as much. Just small things like that. The other thing to mention is dexamethasone is obviously a steroid and tends to push up blood sugars. So again, just get in contact with your diabetic nurse because it's really important that we get it right. Taste changes. This is quite new to COVID-19. Obviously, I've worked in respiratory before and respiratory illness, but taste changes is not something we typically see. This is a pretty tricky one, to be honest, because a lot of patients have this, but they're so incredibly varied, and I really can't seem to narrow down exactly what the issues are. Sometimes I get patients say it's bland, sometimes I get patients saying things taste like mold. And I guess it's just really important to mention about having an individualized approach with all of these patients. Again, going back to your basics, your kind of taste buds, your sweet, your sour, your salty, your bitter, your umami, and then the fat flavor taste. Thinking back to some of those as well, I find that a lot of these patients really like sharp and sour taste, things like lemon. But again, it's very varied per person. Gastrorelated symptoms, again, something which doesn't always come up in respiratory illness. A lot of these patients are having loose stools, and we know that COVID can actually be found in feces. And the other thing to mention with that is we're just a little bit worried about whether they're absorbing. We're also finding they're getting a lot of like abdominal discomfort and bloating. And something I have found quite helpful, again, it's quite 50-50 whether it helps or not, is if these patients are enterally fed, I found that we're using a lot more of these drainage bag systems, such as the Pharrell bag. And this is really helping. It's a closed loop system, which helps to get some of the air to escape into that bag. We usually use them in long-term ventilation, but it's actually quite helpful in COVID patients. The other thing which has been really helpful is actually peppermint water. And this is actually something which the doctors need to prescribe, so not something from the kitchen. Again, a 50-50 chance about whether it's working, but anecdotally, patients are saying that it's really helping to soothe their symptoms. Ventilation. So obviously, it can be really challenging to meet these patients' nutritional requirements and get enough energy into them when they're on a face mask. And typically, when patients are on face masks, they know they're not going to meet their nutritional requirements orally. The other thing to mention with this is obviously there is a seal around the nose of the face mask, and sometimes that can put medical teams off of putting NG tubes in. It's just really important to, I guess, relay this information to the doctors and to explain the importance, and also to work with them. If you can get a smaller NG tube so the seal is less broken, that can be really helpful as well. Shortness of breath. So these patients are so breathless, like they can barely talk, you can barely engage with me, and then I'm expecting them to eat a whole meal. It's just impossible, to be honest with you. And especially when they're on masks, it can just get too tricky. And by the time their meal times are over, their meal has gone cold, they've only managed a few mouthfuls. It's about getting nutrition in as quick as possible. And so often what I found during this pandemic is I'm shotting up the protein-based oral nutritional supplements and getting the nurses to give them in a shot form. So just literally getting them down, and that's the best that we can do for now. Dry mouth, again, with the oxygen therapy and the shortness of breath, this is something which is just really common and really impacts people's pleasure of food and appetite as well. So I guess some tips for this is just making sure that there are fluids always there. If I could literally switch out jugs of water to jugs of juice and milk, I would love to do that all the time. I guess things like chewing gum and hard-boiled sweets to help produce saliva, that can be really helpful. The other thing to mention is actually like artificial saliva. And again, with the pandemic, I'm finding that patients are actually liking sometimes more of the lemon flavor one than the normal one. Lastly, I just want to talk about fatigue and food insecurity. After COVID, these patients are incredibly fatigued, so it's just important to think about that in terms of food preparation and ready meals, and thinking about like batch cooking and that kind of thing. They often don't have the energy to be cooking like they used to. As I run a clinic as well, one of the biggest and saddest things that I'm seeing is a lot of patients are coming in with food insecurity. So I'm trying to tell them to increase what they're eating, and they would actually be willing to do that, but they literally can't get out to the shops. What I found really helpful in this pandemic is linking in with local councils who often have really good resources. And in particular, what I found helpful is resources for, they know, like volunteers of who can drop off extra food and things like that. So linking in with those councils are really helpful in this pandemic. Communication, like I think everyone else has probably spoken about. PPE. So dietitians are like, the big part of our job is building rapport with patients, dietary counselling, and how can we do that when we look like this? And I wasn't going to share this photo because it wasn't the best, but this is just the reality of what happens when you're working. I'm in a crumpled gown, you can barely see my face, and I'm supposed to be reading someone else's face and lips, and they're supposed to be interpreting my body language and face, and it's just impossible. I think it's really important to be checking in with your patient regularly to see if they can hear you, if they can understand you. Sometimes even getting them to repeat back what you've said can just be really helpful. I'll also talk about something in a second more about this as well. Outpatients. We know that a lot of outpatient clinics have been stopped, and we've moved a lot to virtual clinics. And whilst I think that is definitely a good thing and it will definitely continue, there are obviously some downsides. Patients don't always have scales. It's really hard to eyeball patients. And sometimes, again, it can just be really difficult to build that rapport. Within the dietetic team, so it's just really important with everyone being so stretched that we work together as a team and everyone's checking in with each other and we're prioritising the highest patients. Daily communication is definitely what needs to happen so that we don't miss any patients and give everyone the best care. MDT working. So again, this is one of the most important things, working with the teams. And again, going back to kind of the PPE situation, the reason why it is so powerful is because If you can, work with your MDTs, for example, thinking of other ways to communicate with patients, such as creating charts like I've done with the physio and psychologists here, but also charts for patients so they have something visual to look at. That can be super helpful for patients so that if they don't fully grasp what you're saying verbally, that they have something to fall back on. I quickly want to touch on redeployment. So a lot of people don't realise that I've actually been redeployed 50% to critical care, and there is a lot of redeployment within dietetics. So I know that diabetes dietitians who do education are being redeployed into nutritional support and that kind of thing. There's also a lot of redeployment outside of dietetics into proning teams, into HCA jobs, and even more senior and kind of up the chain. I know that there are dietitians who are running COVID vaccine clinics. I guess it's just important to mention that you might be a part of this, and it's just important to be flexibility and just take away all the positives from the experiences that you've had from any form of redeployment. The most important thing, and one of the things which I think everyone is struggling with COVID, is teamwork. I think the big part of being in the NHS and something I absolutely loved about it is if I had a good day or a bad day, I would go for dinner and drinks with my colleagues. And I like going to conferences and like doing things with my colleagues. And now that's obviously been stopped. And everyone's morale is pretty low. Even just kind of yesterday when our lung team lead was going round, I don't think there was one person who said that they had a good week this week. And I'm not trying to say that to scare anyone, but this is the reality of what I guess you're coming into. Some people will have good weeks, some people won't. And I think it's just really important to make use of everyone around you and your wider MDT. Things like Christmas parties have obviously been changed to Teams, meetings have been changed to Teams, and it's really important if you still can get involved, to get involved, because these are still really good rapport building exercises and really good ways of getting to know your other team members. Taking time out for yourself is also really important. For example, our team put together over Christmas some COVID-safe cookie decorating, which is in the right-hand corner, but obviously making sure you're looking after yourself as well. Looking after others as simple as literally if you're making a cup of tea, asking someone else if they want it. In the left-hand corner are some doctors, and whenever I come and see them, they are honestly the kindest doctors ever. They always offer me pizza and cake, and they just know how to make me happy. And that's just a really nice way. It makes me feel really good when I'm having a bad day. My final thoughts are just that when I was a student, I was always so worried and anxious, and I still am as a qualified dietitian, about speaking up and asking for help. And I was like, should I know this information? Am I being annoying by asking someone information? And actually, the biggest piece of advice I would give is, especially in a pandemic where not everyone knows everything, is to talk up, and please don't feel like you're a burden. Everyone deserves to be supported, whether you're a student or qualified, and it's really important that you get that support if you need it, and you are not burdening any of us. It's really important that you have a good student experience and that we also have a good teaching experience. And I'm really lucky to have my team obviously on the right-hand side supporting me all the way, and they always pick me up when I'm down. That's all I have to say for now, but you're always welcome to contact me. Yeah, if you've got any questions.
Oh my goodness, I'm a like emotional wreck here watching that, Raz. I have to say, there is, I'm sure you can log into YouTube and read the comments about you. There was actually a couple of comments about students, about how dietetic students can get more involved in this COVID era. Some people are a bit reluctant, you know, going into different areas. What top tips have you got for people?
I think, yeah, I think that's even like a good question for just like everyone generally. It's about going with the flow, and I find that like that's really challenging. That is really hard because you're going into the unknown, and I've had loads of feedback from people who've been redeployed into other areas. Some really like it, but some are like, well, this isn't what I love, this isn't what I want to do, this isn't what. But then other people have like found real value in it. So they found like, oh, being a HCA, actually in the future, this can help with nutrition and this can help with dietetics, and they can do X, Y, and Z to help in the future. So I know it is really daunting, and it can be challenging when you're obviously in a situation where you don't really want to do it, but I guess just go in as best as possible with an open mind. Again, use your support system around you. You can always DM me and chat about it if you need someone to bounce off, but just go in with an open mind, take away the most positive experiences you can, take away any learning points you can, and I think it will build into your, I guess, your profile in the future and your experience in the future.
absolutely. I'm going to stop sharing now. So anyone who wants to take a quick picture of the screen, please do. But the slides will be up forever. Just a couple of tips about nutrition. So these are really great questions, actually. So at what point, think about the post-discharge patient, COVID or not, but COVID is particularly bad. And they have lost a lot of weight or they're malnourished. What tips do you have for families or others that can help build their nutrition up so you can nutritionally optimize them before referring on to a dietitian?
Yeah, definitely. So first line advice and like the food first approach is definitely super important in COVID, because it's just about getting things right for the patient and what they like. I think people often worry about having this like healthy, balanced diet. And actually, when people are unwell, we don't really need to worry about that for now. That can be changed later on once they're feeling a bit better. I think it's really important just to get any nutrition down when they can, no matter what the food or drink is that they like. Getting in some protein where possible, ensuring you're trying to get main meals down as opposed to like soups and desserts, which are typically not very energy dense, regular snacks, and then just keep liaising with your GP. Obviously, we talk about food fortification as well, so things like adding extra butter and cream to make foods more nourishing without increasing the portion size. But that's very dependent on what patients like. But generally, just give the patient who's lost a lot of weight whatever they want, and just be a little bit patient with them as well.
Thank you so much. Please log into YouTube and see these chats, honestly. Honestly, they're just so amazing. So thank you for your time. Please reach out to us. She really doesn't mind. She's amazing. She's a massive advocate for students and education. So yes, thank you so much for your time.
Thanks, Rachel.
Thank you. Now our next speaker is Steph, and I'm delighted that Steph is joining us. Steph is a paramedic and has done some talks with us before. So she's a font of all knowledge, and this is going to be just a chat. This is going to be a conversation about paramedic science, and all the extending roles that you can have. So I want to first start off, Steph, by asking you to introduce yourself and just say where you work, what you do, and maybe a little bit about your career pathway so far.
Hi, Rachel. Once again, thanks very much for the invite. I'm very pleased to kind of come back again. I had so much fun last time, so hopefully it'll be the same this time. And so good afternoon, everybody. See, my name's Steph. I am a specialist paramedic and I work down on the South Coast. I've been a paramedic now approaching pretty much 20 years, so I've been there, seen there, done it, should we kind of say. Pathway when I started was before it was all academic, so my pathway was kind of the cram of all knowledge in the classroom. You learned it, you binned it, you moved on, and that was the kind of way it kind of went. Happily, we have moved on now and we've become more academic, which I think is the right way to do, the right way to kind of go. And so in 2004, I qualified as a paramedic. 2013, at the ripe old age of 44, I decided to branch out and tread uncharted waters and go into university and studied at St George's Medical School for 2 years, where I then became a specialist paramedic, or paramedic practitioner as they know. You may have come across some of the paramedic practitioners now who work in GP surgeries. They go out, but I've decided not to hang up my greens. I think if you cut me in half, I have ambulance kind of running through my middle, maybe in pink, but there you go. I took my specialist paramedic exam, so I am now a specialist paramedic. On top of that, taking pretty much almost the same as a GP's exam. I don't know how I got through it, but I did. And obviously then moved on and now into an operational team leader role, unfortunately suffering quite a nasty accident while on duty, which meant I am no longer kind of can do the kind of 12-hour shifts on the road, although I still do them from time to time. So in regards to, obviously some of you may have also seen me, because obviously I'm also a trans advocate for the National Ambulance LGBT network, and I am national lead for the trans awareness. So my picture may pop up now and again on kind of the Twitter feed, and I do have a cult Twitter following. And as I said, many of you have joined me this morning, so thank you all for that, and hopefully you like what you see. So going back to your kind of question, Rachel, in regards to our kind of career pathways and everything in regards to the ambulance service. When I joined back years ago, there was only two roles. You started off either as a technician and then you moved on to a paramedic. That was it. As with everything, roles have now kind of diversified, and therefore we have many roles in the ambulance service, and some of the roles even I struggle to get my head around. So we have like the basic, when I say basic role, that sounds rather rude, but we have like the entry role, shall we say, which can be different in different trusts. Every trust may have just a slight difference to all of it. So that comes in what we could be emergency care assistant. With us down here, we have an emergency care support worker, and that's kind of a good level entry for people who maybe haven't got academic qualifications, looking for a career pathway or career progression within the ambulance service. Is something they can kind of come in and then pick up and get. And I think sometimes it's a good way of moving into an ambulance service, because the ambulance service is not for everybody. And I think one thing I kind of need to push out there that I've harped on before, it's not casualty, it's not Holby City. The reality is, and especially in this pandemic and everything, we do a lot more social care work than we do emergency care work. That's the nature of the beast. That's how the role has evolved, and that's why I moved also into specialist paramedic, into kind of paramedic practitioner, working in GP practices and everything, because I could see where the role was developing. A lot of people maybe kind of have that kind of mindset that when they come in, all they're going to do is car crashes and everything. Thankfully, that really is not the case, because otherwise people who kind of come up there leave very, very quickly. So we move on from that, and we do have an apprenticeship program now, which is obviously the AAP, the Associate Ambulance Practitioner. This is pretty much now like adopted nationwide, where people can come in and do, depending if you're an internal or an external person, because the external can jump straight in as AAP, and you do a 2 or 3 year course appropriately, where you kind of work on the road and obviously then do lots of kind of classroom learning. And from there, obviously, it's the paramedic. Again, people can circumvent all of that and apply directly to your local universities, and you only have to go onto NHS jobs and see, obviously, when the recruiting goes out, and you can go direct straight into paramedic. Again, that's usually a 3 year academic course, and if you're internal, it's usually only a 2 year, but with criteria as some of the old people like myself kind of finding and everything up there, when you did your exams way back in the 80s and 90s, sometimes you need to kind of get a couple more qualifications, shall we say politely, just kind of refresh your knowledge and come up. Now, when we get to kind of paramedic level, this is where we kind of differentiate across different trusts. Some trusts kind of almost cap yourself there, but I know my trust doesn't. And I know kind of London, I think other trusts are coming on board. You can specialise. So you can specialise in specialist paramedic in urgent care, like myself, or you can do specialist paramedic in critical care. So these are the people you see rock up at all the nasty jobs, shall we say, and they're the people that come out the helicopters and everything up there, which seems to be the more desired pathway from the new recruits, shall we say. Again, it's not for everybody. And within our trust as well, we even go from there, we can go to advanced practice, and where we now go paramedic prescribing, and you can even go to the dizzy heights of consultant paramedic if you so wish. So the world is your oyster, shall we say, Rachel? The world is your oyster.
I'm speechless. So there's a couple of comments, especially around the delivering babies bit. I mean, I think, I've just learned so much in those last 5-10 minutes you've been speaking. Now, when we think about paramedics, and I think this is the problem, isn't it, Steph, with our professions, if you've had experience with an allied health professional, whatever it might be, that's your kind of link. So all the public see, and if you think kids see about paramedics, is the kind of like 999, the Holby City, the casualty, that type of work. So it potentially can be quite off-putting for people, like you said, because a lot of people don't want to deal with that life or death situation. A lot of people, there's 3 types of people in emergencies, isn't there? The people that run into the burning building and want to save everyone and save everything. There's the people that kind of want to do that but aren't that brave, so they just sit there with their smartphones recording everything. And then there's the people who physically run away, who physically just don't want to say anything. So what would your advice be to people who, do you say, is there a particular type of person that would go and do we need to get rid of this conception that it's the people that want to run into the burning building, that there's so much more?
I think it takes all types. Let's kind of be honest. We live in diverse nature as it is, so there's roles for everybody. I have seen, obviously, in people come and people leave. People kind of, I think they need to come and experience it. That's why I said, obviously, with the emergency care support worker kind of role, it's that dipping your toe in the water type, isn't it? When you can kind of come in and you can kind of see how it is. And like you say, some people, when they come on station, and their expectation, as if you said, is completely driven by what they see on TV and everything, and they're pretty unrealistic. I think I did statistics one time of out of hospital cardiac arrest survival rates. As we know, unfortunately, within the UK, we kind of sit at a kind of a 9%. It's something we're working on. And I think they did the same for casualty, and it turned out like a 74% survival rate. So it's kind of putting out there like an unrealistic kind of, one shock and they're sitting up and they're drinking tea is not really the kind of thing that kind of, as we know, happens. But it takes all types. Let's be honest, and I think sometimes you need all types to make any service, not just paramedics, but any allied health professional. Everybody has a kind of a role. So I wouldn't turn around and said that we don't need everybody, because we do need the people that kind of do run into, which I have been known to do myself, and everything kind of run into the things. You need the people, as well as those people who kind of stand back and everything go, that's not for me, but I'm more happy in kind of that social side of it. So don't put off anybody from applying. But what I would say, if anybody's thinking of going down the route, have a chat with a paramedic, get it firsthand. Some of the programs you see on television inside the ambulance or rescue medics and everything, they're only going to show one certain side because it's a TV program and they need to encapture viewers. Yes, we do go to those jobs, but if you actually think those jobs are probably spread over like 2 or 3 weeks to try and make the program up. So trust me, it's not like that all the time. Otherwise, people will burn out really, really quickly.
Well, it's good that you said burnout, because that's there's a couple of related questions to that in the chat. About PTSD and paramedics. So if we think about the super extreme stuff, the first on the scene stuff, might even be the delivering babies, because not every, sadly every, premature birth, labour is always a favourable outcome. So how do you prepare for that in paramedics? How do you deal with these life and death situations?
So I think in the old days, when you kind of first joined, it was a kind of like, this is what you joined up for, this is kind of what you need to do, kind of suck it up attitude. But I think a lot of research has kind of come on from that, and we've taken something from the military. I don't know if you heard of the TRIM. So it's like a trauma counselling type of thing, which we've picked up from the military. So obviously in the military, they see kind of the short, sharp contacts, which kind of give them PTSD, but it's then recognised that a repeated exposure to these kind of events can also have that negative effect with mental health. So you find a lot of trusts now, ours included, have what's called the Wellbeing Hub. So within the Wellbeing Hub, they employ mental health practitioners. So I know, particularly in my trust, we have a really good, robust system like that. So where the mental health practitioners are available for you to have their appointments with. I mean, I'm lucky on my station that we do have one that kind of sits there. So it's even to the point when she's not busy, you can just walk in her door and kind of sit down, and she put the kettle on and you can kind of offload. As a manager, obviously I go out and I'm kind of first on scene to these jobs because that's what my role is. And it's identified that this repeated exposure is not going to do anybody any good. As you said, delivering the babies, and even if we kind of bring it really up to date with kind of the COVID, because obviously now we're having to make some really quite significant decisions on the ongoing care of people with kind of COVID that have not got favourable outcomes, where in normal kind of times you would kind of have no problem taking them into hospital. Now there's a little bit of a different mindset, and that can affect you and play heavily on your mind at times. I know it does for quite a lot of people. So therefore we have that facility that, I mean, obviously unfortunately COVID again, the face-to-face meetings have kind of dropped out a little bit, but there's always like a Zoom or a Teams meeting, and you can always do a kind of a face-to-face where they can put support in, and even ongoing support and everything, with the ambulance service charity kind of stepping up and everything. So it's a massive shift from when I started to now, the realizing we don't have this kind of suit of armor on all the time. We don't kind of deflect everything. Underneath that armor is a human being, and that human being, the same as everybody, gets affected emotionally and physically from some of the jobs that we do go and see. And we take that seriously now. We really do take that seriously. Mental health is a big issue, and if anybody's thinking of coming on there, look at the trust page, look at the trust web page and everything, and look at their well-being set up. I know, say, mine has a really quite robust one, and have a look, and use them. I always advocate that the people are here to use, and I've used them myself. Unfortunately, recently I've been diagnosed the same thing with PTSD after 20 odd years. That is some of them that even I didn't realize. And when they talked about it, and I kind of imploded, and I went, wow, where did that come from? So nobody's infallible, and I think that we need to kind of put that out there. Nobody's infallible.
Thank you. Some lovely comments about that, actually. More comments about babies being delivered by paramedics. So I love that. Now there's some very interesting comments around PPE and how it's affected your care, but I just want to kind of go back a step into some of the other roles, because what I think is the future and what I love is when I read these stories about paramedics working with like occupational therapists or with physiotherapists in emission avoidance, and using the paramedic skills and then using the therapeutic skills to actually care for the patients at home, and that point saying, actually, when is this patient unwell, they need admission. Have you got any experience with that or comments about that?
So obviously down in the trust, we don't have them kind of in the ambulance with us, but what we do have is we have certain allied health professionals in our control room. So therefore, what kind of happens is when we have a call, particular, whether it could be mental health, we have midwives, mental health practitioners, and we do have access to occupational therapists and everything on there that we can call on their kind of specialists. We've even, I think, got dental nurses now and on in our control room, so we can kind of signpost and help people out there. So I think it's realizing now that it needs to be a joined up approach. It's not kind of one size fits all. We realise that other professions have so much to kind of give in emergency care. You may not kind of think so, but if I go back to what I was talking about at the beginning, where we shifted from kind of the emergency care to more like the kind of the social care, and looking to kind of empower people and keep people back at home, so we don't kind of clog up the A&E system, which is more important now than ever. So we use the skills from anybody that we can do, but we also have good referral pathways. So I know in the middle of the night I can call up a social care, and I can get access to and refer to occupational therapists at night, which is a big thing. I can talk to a mental health practitioner at night, so we can make a plan, and even if that person needs to go to hospital, we can avoid A&E. I can go straight to a psychiatric unit, shall we say. Go back to babies, babies seems to be the theme of this kind of talk. So in regards to the midwives can kind of pre-alert incoming hospitals. They can arrange community midwives, so by the time you come out, you're there just in case. I mean, it's always a great feeling, if I'm honest. When I deliver a baby, I always find that kind of one of the nicest things. Flip side of that, unfortunately, I've had obviously little ones die in my arms and everything. It's the nature of the beast. But there's so much now kind of support, and all I got to do is just call up on my radio, and I've got a midwife sitting on my shoulder. And trust me, there's no greater feeling when the adrenaline's going, it's not going right, that you do have a midwife sitting on your shoulder.
So, Fiona, I don't know if you read my mind there about OTs going out, but yeah, that's exactly what I was thinking. And I think it's like in the Northwest it started in the cars, not in the vans. But I just think that's a really interesting concept. And I know there's one organisation that had, I mean, it's not about money, but it was more about admission and actually people, say, frail people at home. But it's also respiratory input as well. So sometimes people with, in respiratory crisis, actually, could they be managed at home with some medications, with some oxygen therapy? Does there need to be that admission? I like it. I like that collaborative working.
But it's the way forward.
Yeah.
As I said, in the end of the day, we are diversifying as a service. I mean, we haven't got, say, OTs on the cars with us at the moment, whether it comes in. Obviously, it's kind of like a region by region thing, and obviously what will happen if one service kind of picks this up and runs with it, you can ensure that all the other trusts are kind of having a crafty eye over the corner and saying, how does it work? Where does this fit in? And how would it kind of work for us and everything? For us down here right now, that's kind of a no. I think the only people we have on cars, would you believe, right now is joint police officers, where we have kind of a joint response unit. So obviously people who may be sort of drunk or mental health crisis, we can go and we can deal with those people there and kind of signpost them straight on, so they don't have to go to hospital, and we don't tie up lots of ambulances and lots of police cars in an instant. So that's where we're kind of sitting with right now. All our allied health professionals, we've kind of moved into their control room and urgent kind of care now at the moment. So I won't say it's not coming, but at the moment we don't have that.
I completely agree. There's just a couple. I'm going to ask you one final comment about COVID and PPE and how that's affected like emergency, like, you know, and actually there's, without going down that road about aerosol generating procedures and CPR, etc., because obviously you guys have been completely, well, in my opinion, shafted over that. But there's lots of comments about transfers, like paediatric transfers. Obviously, there was quite a lot in the media a few weeks ago about 999 calls, but also about the number of patients that were having to be transferred, say London to Newcastle, London to Birmingham, Birmingham to Manchester. So I think that's another role of transport as well for critically unwell patients. What a responsibility that is, being a crew.
So I think if we kind of pick up on that, and kind of especially with this COVID pandemic, we suddenly find ourselves in kind of uncharted waters, and all of a sudden we had to do a lot of kind of changing. We got lots of kind of learning very, very quickly. As if I go back to kind of the early days of COVID and everything, and we pick up on PPE and everything, there was so much conflicting evidence kind of coming out. 1 minute it was okay just to kind of just pop a normal mask on, you'd be fine, get a wipe and just wipe everything down. I mean, in the end, if you think before, we've had bird flu, SARS and everything, so it's not like we weren't kind of been exposed to potentially harmful stuff before, but this was different. And then all of a sudden we realized not only was it affecting our mode of work, but obviously the hospitals and everything, capacity was kind of reached. And as you said, then we had to kind of think, hang on a minute, we need to kind of have the facility built in to try and transfer people away. So they were, I know in our trust, we had the big jumbulances. So we did, and therefore we put our specialist paramedics, we put the critical care paramedics team, they were specially trained, so they could kind of provide like a mobile intensive care if they needed to kind of move from out of our area up into the Nightingale hospitals and everything. And also we go back to specialists, we obviously have the heart team. So the heart team now have specific designed COVID ambulances. And obviously because they have more kind of heavy duty PPE and respirators and breathing apparatus and everything, they're well suited to kind of handle these kind of long distance transfers and up there. So if we were to get one of those, then the logistics kind of set in. It's managed really centrally in the UK. All the ambulance services come together and realise that we need to kind of sing from one voice, and they organise it. I think it's called the NAC, for National Ambulance Command Centre, or something like that. I can't off the top of my head, but it's all coordinated from one kind of place. We all sing from the same hymn sheet, and we realise now that, you know, we do need this kind of specialist kind of PPE, and therefore it had to be stepped up to provide this level of care with these long duty transfers. But also kind of the flip side of that, obviously you've obviously seen in the pictures on the news and everything of ambulances queuing outside of hospitals. So therefore we have potentially crew sitting in the back of the ambulances looking at after really unwell people for an extended period of time. So where do we look for PPE for that? So obviously you need to make sure that our PPE is robust. We need to understand that, you know, anybody on here who knows working in PPE for an extended period of time, it becomes very draining. You fatigue very, very quickly. So we need to kind of understand that we may have to swap crews around. We may have to bring other people in. On the flip side of that, you talk about cardiac arrest. You put a full cardiac arrest in, and you have a couple of teams working tirelessly on a patient in the full PPE, mask, visors, gloves, everything up there. It really, really is hard work. So potentially then when people come off of that, then there's going to be a certain element of downtime that you need to kind of rehydrate the people and kind of get that before they can come back in. So if you think you're kind of losing losing staff there for a little bit, and it's then you probably see around again, we have military aid and everything kind of coming now and kind of helped certain services out there to provide support for this. So we're working in different times. Like a pandemic's a once in a life, thank goodness, once in a lifetime thing. And I think, if I'm honest, we're still learning as we're going on, even now.
Absolutely, and hence we're here today. So on that note, because are you in between shifts, night shifts or something? What are you doing? Oh, you're amazing. So you're sacrificing your sleep for us as well.
Exactly.
Oh goodness, honestly, so a massive thank you, honestly, from the bottom of my heart. The chat is incredible. You're inspirational. Thank you for all your hard work, and please reach out on Twitter if you want to ask any more questions. And
exactly.
Thanks for your time.
Ask any questions. If you want me, Twitter handles on there, and I'll ask them. If not, I'll refer them back to you.
Okay, well, thanks so much, Steph, for your time. Really appreciate it. So everyone, see you. Bye. Everyone, we are having a 15-minute break now. So please join us back at 1:10. So in 15 minutes, 1:10, we'll be talking about music therapy and clinical psychology. Now, with Melody's chat, we do have a link into her YouTube channel as well, which is amazing for budding clinical psychologists. And again, will be available to view after the event. So please go and have a 15-minute break. We'll see you back here at 1:10. Thank you very much.